Hello everyone and welcome to our module on trauma basics. When evaluating a patient who's been involved in a trauma, the first thing you do is called the primary survey. And the goal of the primary survey is to identify life-threatening injuries. And most people remember the elements of the primary survey by the mnemonic A, B, C, D, E. A is for airway, B for breathing, C is for circulation, and D and E are for disability and exposure. And we'll go through each of these one at a time in the remainder of this video. Let's start by talking about airway. Patients have to have a normal airway after trauma in order to survive. And you can quickly determine if the patient has a normal airway based on whether or not they are conscious and speaking in a normal voice. If patients are conscious and speaking normally, then they can be presumed to have a normal airway. And so when patients are brought into the trauma bay, you'll see your attendings talking to the patient, asking them if they have pain or other questions. And what they're really doing is assessing the airway, because if the patient is conscious and able to respond to their questions in a normal voice, then that means the airway is patent. When patients have a compromised airway, you have to establish an airway. This is the first thing you do in trauma before you do anything else. And the most common way that an airway is established is through orotracheal intubation. This is a picture of what it looks like on the screen here. A tool called a laryngoscope is used to lift up the lower jaw, and then a tube is inserted through the back of the mouth and into the trachea. In some patients, you may be unable to get the tube into the trachea. This could be because of airway collapse or hematoma, and when that happens, you need to do what's called a cricothyroidotomy. This is the backup option to orotracheal intubation. This involves making an incision through the skin and the cricothyroid membrane, and then a tube can be inserted into the trachea, and that can be used to ventilate the patient. Shown on this slide are some of the major indications for establishing an airway through intubation. The first one is a very low score on the Glasgow Coma Scale. We'll talk more about the GCS later in this video, but if it's less than 8, that's very low, and that's generally an indication for intubation. The second one is if the airway is compromised from either obstruction or collapse. The third one is oxygenation or ventilation failure. If the patient cannot ventilate their lungs and oxygenate their blood, they need to be intubated and put on a mechanical ventilator. And then the last one is anticipation of rapid deterioration. If the patient comes in breathing with a patent airway, but you expect that they may deteriorate quickly in the near future, then you should intubate, because it usually gets harder to intubate after a patient deteriorates compared to before. Once you've determined that the airway is patent or you've established an airway, the next thing to do is to evaluate breathing. This is fairly straightforward. You check for breath sounds on both sides of the lung with your stethoscope, and you measure the oxygen saturation on pulse oximetry. If the patient has a patent airway but their breathing is abnormal, as we talked about 2 slides ago, that's one of the indications for intubation in a trauma patient. After breathing, the next item in the primary survey is an assessment of circulation, and this begins by checking the pulses. If a patient has no pulses, then you need to begin CPR and go down the pathway in the ACLS algorithm that I discuss in the cardiology section. After you check pulses, you need to establish IV access. The usual way this is done is through 2 16-gauge peripheral lines inserted into peripheral veins in the arm or the hand. An experienced provider can usually get peripheral IVs in very quickly, so this is the fastest way to get venous access, and 16-gauge lines are large bore so that lots of fluid or blood products can be administered quickly. Some patients do not have good peripheral veins, and so if you're unable to get peripheral venous access, the next option is an intraosseous line. This is a picture of an intraosseous line shown on the screen here. You insert these using a mechanical device that forces the needle into the marrow of the bone. This is usually done in the leg and the proximal tibia, and then this can be used to infuse drugs, fluids, or blood products. And I've emphasized this in my last bullet point. If you can't get a peripheral line, you want to do an intraosseous line. That's because that is the fastest way to get venous access after a peripheral IV. Beyond a peripheral IV and an intraosseous line, the next option for IV access is a central line. Central lines are large infusion devices inserted into the subclavian vein, the jugular vein, or the femoral vein, and they are extremely helpful in trauma patients, but it takes time to insert central lines, so they are not the first option. The first option is something that is quick, which is going to be either a peripheral IV or an intraosseous line. Besides checking the pulses and establishing intravenous access, part of the assessment of circulation is to examine the patient for signs of shock. In a trauma patient, shock is usually caused by hemorrhage and blood loss, although, as we'll see later, there are some other reasons patients can develop shock after trauma. And evidence of shock that you might see on your primary survey include things like hypotension, weak pulses, pale, cool skin, poor capillary refill, or cool extremities. Any of these findings are ominous signs in a trauma patient, and you need to very quickly move on to figure out why they are in shock and to address it. So like I said, the most common cause of shock in trauma is hemorrhage. Patients develop hypovolemic shock from massive blood loss and hemorrhage. This leads to clinical findings like we talked about on the last slide, things like weak pulses, cool skin, and low jugular venous pressure. FAST stands for Focused Assessment with Sonography for Trauma, and a FAST scan is a bedside ultrasound that's used in trauma with the goal of identifying free fluid in body cavities that is presumed to be blood. So as part of the assessment of circulation and the evaluation for hemorrhage, ultrasound is often used in the trauma bay to look for fluid in body cavities that is presumed to be blood. And there are a couple of classic areas where blood collects internally. These are places like the right and left upper quadrants, the pelvis, and around the heart, causing a pericardial effusion. So in the trauma bay, you'll see your attendings using the ultrasound and quickly assessing these key areas, and if they see a finding like what's shown on the screen here, where there's fluid between the liver and the kidney, that's evidence of intra-abdominal bleeding. And I talk about use of the FAST scan in some of the other videos, like the ones on chest trauma and abdominal trauma, and basically the FAST scan is the use of ultrasound to supplement the physical exam during the primary survey as part of assessment of circulation and looking for sites of hemorrhage. Just to emphasize this point a little further, hemorrhagic shock requires loss of about 1.5 liters of blood, and this is a lot of blood, and there are several common locations in trauma patients where this much blood loss can occur. First of all, you can lose 1.5 liters through external blood loss, so patients who are hemorrhaging from wounds to the neck can easily lose 1.5 liters of blood. You can lose this much blood into the chest in the form of a hemothorax. You can also lose it into the abdomen if there's a liver or spleen injury. Spleen injuries in particular are classic for causes of massive blood loss, and I talk about this in the video on abdominal trauma. In the pelvis, a pelvic fracture can cause massive blood loss, and then you can also have a lot of blood loss if there's a femur fracture. The femur is highly vascular, and there's a lot of room for blood loss into the thighs, so the thighs is one place that a large volume of blood can be lost, leading to hemorrhagic shock. So like I said before, the most common reason that patients with trauma develop shock is from hypovolemic shock related to hemorrhage. But there are some patients who develop shock for other reasons, and let's talk about that now. One way you can get shock in trauma besides from hemorrhage is if the patient develops cardiac tamponade. This occurs when there's chest trauma and bleeding into the pericardial space around the heart, causing a pericardial effusion. The classic presentation of tamponade in a trauma patient is with Beck's triad. Beck's triad refers to hypotension, distant heart sounds, and jugular venous distension. And you can image the heart with the FAST ultrasound probe, and if you see an effusion around the heart and clinical findings of tamponade, then the patient needs a pericardiocentesis to drain that blood from around the heart. Patients with trauma can also potentially develop cardiogenic shock. This can happen if there's a myocardial contusion after chest trauma. Chest trauma can also damage the coronary vessels, leading to ischemia. And when patients with trauma develop cardiogenic shock, they will have clinical features similar to acute heart failure. So they can have pulmonary rales, elevated jugular venous pressure. They can also have tachycardia with weak pulses. And the diagnosis is usually made by echocardiography, but echocardiography is just a form of ultrasound, and so you can use the FAST ultrasound probe in the trauma bay to image the left and right ventricles, and if you see that they have poor contractility, that's evidence that the patient has a cardiac injury and may have cardiogenic shock. Trauma patients can also develop shock from a tension pneumothorax, which I talk about in detail in videos in the pulmonary section. This occurs after chest trauma when there's a hole in the lung that allows air into the pleural space. In a tension pneumothorax, the pressure in the pleural space gets so high that it impairs venous return to the heart. That causes low cardiac output. So patients with a tension pneumothorax will have absent breath sounds over the area of the lung where there's a pneumothorax. They can have jugular venous distension because blood cannot drain into the right heart. And you can make the diagnosis by X-ray, and this requires urgent needle decompression. And then lastly, neurogenic shock is a form of shock that occurs in patients with spinal cord injuries. I talk about this in the video on spinal trauma. This happens because of damage to the autonomic nervous system and the nerves that are associated with that system, and this leads to hypotension and bradycardia. When patients who have had major trauma develop shock, you need to resuscitate them. This always begins with boluses of intravenous crystalloid, either normal saline or lactated ringers. If there is obvious severe blood loss, you can transfuse type O blood, and many patients require a massive transfusion protocol, so let's talk about what that means now. So the massive transfusion protocol is used in patients who have anticipated massive blood loss, such as patients who've had a major trauma. The definition of massive blood loss is more than the entire blood volume in 24 hours or more than half the blood volume in 4 hours. Although in actual practice, this protocol is often activated automatically once a patient has received 4 units, because if they need 4 units of blood, it's presumed that they have massive blood loss and are going to need the massive transfusion protocol. The goal of the massive transfusion protocol is to replace cells and coagulation factors that are lost in patients who have ongoing diffuse blood loss and hemorrhage. Blood products are transfused in a 1:1:1 ratio with 1 unit of packed red cells for every 1 unit of fresh frozen plasma and every 1 unit of platelets. And the idea is that the red cells replace red cells, the platelets replace platelets, and the FFP replaces coagulation factors. After circulation, the next item in the primary survey is an assessment for disability. This refers to a very focused neurologic exam. You're only going to focus on a couple of important elements. The first one is to determine the score for the patient on the Glasgow Coma Scale. We'll talk about that in a second. The second one is to examine the pupils for size and response to light. This is because a blown or dilated pupil can be a sign of herniation of brain tissue, indicating a serious intracranial bleed. And then lastly, there's a gross examination for sensation and motor strength in the extremities. I talk about the Glasgow Coma Scale in detail in the neurology section in the video on traumatic brain injury, but by way of review, it's a system for assigning a score to a patient that indicates their level of consciousness and overall nervous system function. It involves tests in 3 areas: the eyes, verbal, and motor function. And the patient will ultimately be given a score from 3 to 15. 15 is the best score you can get, 3 is the worst. For the eyes, the patient is assigned a score of 1 to 4 points. 1 is for does not open eyes, 4 is for open spontaneously, 2 and 3 are in the middle. For verbal function, the patient receives 1 to 5 points. 1 is for no sounds, 5 is for speaking and fully oriented, and 2, 3, and 4 are in the middle. And then motor function is 1 to 6 points. 1 point is for no movements at all. 6 points is for able to obey motor commands. 2, 3, 4, and 5 are in the middle, and they include things like decerebrate posturing and decorticate posturing and withdraw to pain. After disability, the next item in the primary survey is exposure. This refers to completely undressing the patient so you can assess the skin and body surface area, although you want to do this in a way that avoids hypothermia as much as possible. And once the patient is undressed, you want to examine them for injuries in key areas, especially areas that are easily missed where injuries can hide. So some of the key areas are the back of the head, the back and the buttocks, the perineum, the axilla, and the skin folds, as well as just an overall assessment of their chest, abdomen, and extremities. Once you've completed the primary survey, you can move on to a secondary survey. This is a more careful and detailed head-to-toe examination looking to identify injuries that could have been missed in the primary survey. So the secondary survey involves carefully going through all of these areas in the patient to see if there are any injuries that might have been missed, as well as looking at any other wounds the patient could have from their trauma. And then beyond the secondary survey, there is what's known as the tertiary survey. This is really a repeat of the secondary survey looking for missed injuries. And this can be done many times in trauma patients over hours or even days. Basically, you want to constantly be reassessing them because there can be injuries that are not apparent initially but develop over the next few hours or even days, and you don't want to miss these things. So for this reason, you can keep doing these tertiary surveys to look for new injuries that need attention. And that concludes our module on trauma basics.